Hi friends, in today's video we're going to talk about cholecystitis, and if you like this video make sure to give it a thumbs up and subscribe to my channel. Also make sure to check out all the free resources down below on my website as well as the NCLEX study guide. But let's get into it. So what is cholecystitis? It's an acute or chronic inflammation of the gallbladder. There are two different types. So calculus cholecystitis is a gallbladder stone obstructs the bile outflow, and acalculous cholecystitis describes an acute inflammation and the absence of an obstruction by a gallstone. So this is a quick overview of the pathophysiology. So calculus cholecystitis occurs when a gallbladder stone obstructs the outflow. A chemical reaction occurs when the bile remaining in the gallbladder initiates a chemical reaction, autolysis and edema occur, and compression of blood vessels in the gallbladder compromise its vascular supply. Now, this is a much more in-depth pathophysiology chart, but I really love these charts because I think you can take a screenshot and you can print them out, and it kind of tells you exactly what's going on in a nice little picture. So again, we can see, the gallstones are causing physical trauma to the gallbladder wall, or they're blocking the duct, which leads to irritation and increases the gallbladder lumen pressure and decreases the blood flow, which leads to ischemia, gallbladder necrosis, inflammation, loss of gallbladder structure integrity, which can lead to a bacterial invasion and inflammation of the gallbladder. And then over time, continued inflammation can cause complications such as perforation or gangrene. We can also see that the bacterial invasion causes inflammation, which self-perpetuates that cycle. And then we can see over to the right that irritation of the gallbladder wall irritates the visceral peritoneum, stimulating autonomic nerves, which can lead to a dull, diffuse abdominal pain that is felt more in the right upper quadrant and may radiate to the back and the right shoulder. Ischemia of the gallbladder necrosis and inflammation triggers a cytokine release, which leads to fever, nausea, vomiting, and tachycardia. The bacterial invasion irritates the parental peritoneum, stimulating somatic nerves. So we may see persistent right upper quadrant pain, abdominal guarding, peritoneal signs, and positive Murphy's sign. And then due to continued inflammation, it can lead to inflamed vessels are more permeable and leak fluid from the blood into the colon, which leads to dehydration. And then it also gives some diagnostic things down at the bottom. So just, I feel like there's a lot of good information on this chart. And it also tells you about to properly check for Murphy's sign. You'll palpate the right upper quadrant with the patient breathing in. Inspiration expands the lungs and pushes inflamed gallbladder down below the rib cage, meeting the examiner's hand, causing pain and premature termination of inspiration. So that is what you'll see with Murphy's sign. So statistics. Although not all occurrences of cholecystitis are related, cholelithiasis, I don't even know how to say this, more than 90% of patients with acute cholecystitis have gallstones. And remember that name that I can't say, cholecystitis, is another name for gallstones. The acute form is most common during middle age, and the chronic form usually occurs among elderly. So the causes, we kind of went over this in the pathophysiology section, but just to review, gallbladder stones, it's impacted in the cystic duct. There can be bacteria, plays a minor role in cholecystitis. However, secondary infection of bile occurs in 50% of cases. Alterations in fluid and electrolytes. So acalculous cholecystitis, which is the one without a stone, is speculated to be caused by alterations in fluid and electrolytes. And bile stasis, or lack of gallbladder contraction, also plays a role in developing cholecystitis. So clinical manifestations, we will see that right upper quadrant pain. We'll see leukocytosis, so an increase in white blood cells because the body is attempting to ward off a pathogen. We'll also see a fever in response to this infection. We can see a palpable gallbladder because it becomes inflamed as the infection progresses, and sepsis because the infection can reach the bloodstream. So different complications, so empyema of the bladder develops if the gallbladder becomes filled with purulent fluid. Gangrene develops because the tissues do not receive enough oxygen and nourishment. And cholangitis if the infection progresses to reach the bile duct. So different assessments and diagnostic findings. So a biliary ultrasound can reveal calculi within the gallbladder and or bile duct distension. This is usually the first diagnostic procedure. They can also do an oral cholecystography, which is also called an OCG, which is much easier, is the preferred method of visualizing general appearance and function of the gallbladder, including the presence of filling deficits, structural deficits, and or stones in the ducts or biliary tree. And this can be done intravenously when nausea and vomiting prevent oral intake, when the gallbladder cannot be visualized during OCG, or when symptoms persist following a cholecystectomy. And it can also be done preoperatively to assess structure and function of the ducts and detect remaining stones. We can also use an endoscopic retrograde cholangiopancreatography, or an ERCP, which visualizes the biliary tree by cannulation of the common bile duct through the duodenum. We can use a percutaneous transheptic cholangiogram, or PTC, which is a fluorescent imaging which distinguishes between gallbladder disease and cancer of the pancreas when jaundice is present. And cholecystography for chronic cholecystitis, which reveals stones in the biliary cyst. But it is contraindicated in acute cholecystitis because the patient is too ill to take the dye by mouth. We can also use a non-nuclear CT scan, which can reveal gallbladder cysts, dilation of the bile ducts, and distinguish between obstruction and non-obstructive jaundice. We can do a hepatobiliary scan, which may be done to confirm the diagnosis of cholecystitis, especially when barium studies are contraindicated. They may use an abdominal X-ray, which radiopack calcified gallstones present in 10 to 15% of cases. Calcification of the wall or enlargement of the gallstone will be seen on this. They can do a chest X-ray to rule out respiratory causes of referred pain. They can do a CBC, a serum bilirubin amylase, which will usually be elevated, and a serum liver enzyme, which is AST, ALT, ALP, LDH, which usually there's slight elevation in those. All right, we can also look at prothrombin levels, which are reduced when obstruction to the flow of bile into the intestines decreases the absorption of vitamin K. We can do an ultrasound. This is usually the preferred initial imaging. We can do a CT scan, which is usually the secondary imaging test that they do to identify extra biliary disorders and acute complications. We can look at an MRI, which can confirm the diagnosis of acute cholecystitis. We can use that oral cholecytography, which is the preferred method of visualizing the general appearance and function of the gallbladder. And we can do a cholecystography, which reveals stones in the biliary system, and an abdominal X-ray. All right, so medical management. So the first thing is fasting. These patients may not be allowed to drink or eat at first in order to take stress off the inflamed gallbladder. They may need IV fluids to provide temporary food for cells. Supportive medical care, this includes restoration of hemodynamic stability, antibiotics for gram-negative enteric flora, and gallbladder stimulation. So daily stimulation of the gallbladder contractions with IV chlorocytokinin, which may help to prevent the formation of gallbladder sludge in patients receiving TPN. So this medication, it's called chlorlocytokinin, actually is given IV, and it stimulates gallbladder contractions. So for pharmacological therapy, we can also use some antibiotic therapy. So levofloxacin and metronidazole as a prophylactic antibiotic, which is effective against most organisms. Promethazine may control nausea and prevent fluid and electrolyte disorders. And oxycodone or Tylenol may control inflammation signs and symptoms and reduce pain. Surgical management, cholecystectomy is the most common, performed by using a laparoscope and removing the gallbladder, or they can do an endoscopic retrograde cholangiopancreatography, or an ERCP, which visualizes the biliary tree by cannulation of the common bile duct through the duodenum. So our nursing assessment is going to include assessing the skin and mucous membranes. We're going to look at the circulatory system, assessing peripheral pulses and capillary refill. We're going to look at bleeding, so assess for unusual bleeding from injection sites, any bloody nose, any bleeding gums, any petechiae, ecchymosis, any blood in their vomit or any blood in their stool. We can also look at the GI system, assess for abdominal distensions, frequent belching, guarding, or reluctancy to move. So our nursing diagnoses can include things like acute pain related to inflammatory process, or risk for imbalanced nutrition related to self-imposed dietary restrictions and pain. So our nursing care planning and goals can be to relieve pain and promote rest, maintain fluid and electrolyte imbalance, prevent complications, provide information about disease processes, prognosis, and treatment needs. Our nursing interventions can include pain assessment, so observing and documenting the location, severity on a 0 to 10 scale, and character of pain. The activity, so we're going to promote bed rest, allowing the patient to assume a position of comfort. Diversion, by encouraging the use of relaxation techniques and diversional activities. Make time to listen and maintain frequent contact with the patient to improve communication. We're going to calculate caloric intake to identify nutritional deficits or needs. We're going to look at food planning, so consulting the patient about their likes and dislikes, what causes distress, and what's a preferred meal schedule. We're going to promote appetite by providing a pleasant atmosphere at mealtime and removing any stimuli that could make a meal not pleasant. And we're going to look at laboratory studies, so monitoring the BUN, prealbumin, albumin, total protein, and transferrin levels. So our evaluation, these are just some suggestions based off of, how your patient responded. So pain is relieved, homeostasis achieved, complications prevented or minimized, and disease processes and prognosis and therapeutic regimen understood. So discharge and home care. So we're going to offer education. Patients with cholecystitis must be educated regarding causes of their disease, complications if left untreated, and medical and surgical options. Activity, we're going to ambulate and increase activity as tolerated, and we're going to offer a consult with a dietitian or nutritional support to establish a nutritional plan. And our documentation guidelines are going to include the client's description and response to pain, specifics of pain inventory, expectations of pain management, acceptable level of pain, prior med use, calorie intake, individual, cultural, religious, or personal preferences, ability to use resources, plan of care and teaching, response to intervention, teaching, and actions performed, attainment towards progress towards desired outcomes, and modifications to the plan of care. All right, so that is the end of this discussion on cholecystitis. If you guys found this helpful, make sure to give the video a thumbs up and subscribe below, and make sure to check out all the free resources I have down below, as well as the NCLEX study guide. I'll see you next time. Bye.